Good afternoon, everybody. My name is Shida Lakey. I'm an improvement manager with the Person-Centred Outcomes team within the Sustainable Improvement team in NHS England. Thank you for joining us for our first PCOM powwow. As Sandra said, this is the first one of 5 powwows that we've set up to share the learning of the PCOM Pathfinder site and to facilitate discussion around a number of topics that were identified at the recent PCOM Pathfinder Learning Exchange in September. Last December, organisations were invited to submit expressions of interest to become a Pathfinder in developing patient-centred outcomes for children and young people. 8 projects were chosen, and they've been working since February of this year to develop their PCOMs. The 8 Pathfinders are at Great Ormond Street, who have 2 projects, one of which is looking at PCOMs for psychological interventions in a specialist children's hospital. The other one is looking at childhood feeding disorders. Guys and Thomas's, who have developed an animated PCOM for hospital inpatient children. Alder Hay Hospital, which is looking at a PCOM for children with chronic illness. Nottingham Children's Hospital, which is looking at a PCOM for children and young people admitted for self-harm injuries and eating disorders. University Hospital Bristol, which is looking at PCOMs for children receiving palliative care. The North of England CSU, which is looking at PCOMs for young people and families living with asthma. And lastly, Shropshire CCG, which is looking at PCOMs for children and young people who use wheelchair and posture services. So following on from a successful learning exchange in September, we felt it would be valuable to share this learning with a wider audience, and so we've set up this series of PCOM powwows. Today we have Rachel Bryant-Waugh and Lucy Cook from Great Ormond Street talking about developing PCOMs for childhood feeding disorders, and also Georgina Craig from the North of England CSU talking about PCOMs for young people and families living with asthma. In a moment, Paul Gavin, the Strategic Lead for Data Project at NHS England, will be giving you an overview of the Person-Centred Outcomes programme. And then later on, we have Nasser Quill, the Public Engagement Manager from the Public Participation team in NHS England, sharing tips and resources for effective engagement. We'll take questions at the end, and so without further ado, I'd like to hand over to Paul to set the scene for us. Thank you, Paul.
Thanks, Sheila. As Sheila said, my name's Paul Gavin. I'm the Programme Director for PCOMs for NHS England. This programme stems from our desire to pioneer new approaches to measuring quality in healthcare, and we recognise that for this to be effective, it's crucial that patients and carers are given a voice and that their views shape this care that's provided for them. Our desire is fantastic, but we are also mandated to do this in the NHS England mandate, where it states that we should help patients and carers empower themselves to manage and make decisions about their own care and treatment. And more recently, the 5-year forward view mandates us that statutory services must recognise that patients' own life goals are what counts, and that services needed to support families, carers and communities are key outcomes, parts of enablers to the key outcomes of care. So as you already said, we kicked this programme off last year, and the 7 Pathfinder sites, 7 sites, 8 Pathfinder schemes have been running quite well, very well. Yeah, the questions that we are seeking to answer in our programme going forward are: what commonalities exist? We know about PROMs, they've been running for some time, and PREMS is a term that we're using for for a general approach to the experience measured schemes that are being facilitated around the country. We're also keen to learn from the Pathfinder sites, and the learning that we receive from them will help shape our policy moving forward. And being commissioners, we're really interested in the proposal that can we aggregate personal outcome data for secondary usage. We're still finding that out, and the work that IQ are doing in this financial year We're hoping will lead us down that path some way and provide maybe pointers to the feasibility of that moving forward. And ultimately, if PCOMs stay true to their ethos, we are keen to understand where and when does the NHS stop being solely accountable, i.e. when does the more community-based schemes come in and absorb, not the pain, but absorb the responsibility of achieving these goals that are stated as being successful outcomes for patients. And yeah, we're really interested in that. So as I said, the work that's ongoing at the moment is shaping our policy. We will look to announce that policy at early next year, and then we will work in communicating that to the community so that we can springboard into 16-17 with momentum, retaining the impetus that we're hoping to gain. So as you can see, phase 1 is ongoing, and phase 2 is ongoing also. The key output that we're looking for is this wider evidence scan that NHSIQ are going and to be providing to us. I think the end date is end of January is the submission date, which then allows us a bit of time to absorb and then communicate that to the wider community. So that's all I'm going to say for setting the scene. I have that slide, but I recognise we're taking questions at the end, so I'll hand back to Sheila.
Thank you very much, Paul. So I think we'll go straight over to Rachel and Lucy so that we can hear about your work.
Welcome, everybody. My name's Rachel Bryant-Waugh. I'm consultant clinical psychologist and lead for the feeding disorders service at Great Ormond Street Hospital. And I'm here with my colleague Lucy Cook, who's a research psychologist. And we wanted to just take you through a few slides telling you about the work that we've been doing, developing person-centred outcome measures for childhood feeding disorders. So just to talk you through a little bit the background to engaging in this project, we know from research that parents are actually quite good at identifying feeding and eating difficulties in their children. And we also know that they very frequently express concerns about their children's eating in terms of health and social consequences, often seeking help from primary healthcare providers. And there have been a couple of studies that have suggested that in a significant number of cases, unfortunately, clinicians, for one reason or another, don't address those concerns. We also know that feeding difficulties are associated with quite high levels of parental anxiety, that can increase conflict at meal times, and that in turn can increase risk of later development of an eating disorder. So putting these various strands of research together, it seems very important that timely and appropriate attention to issues that matter to families is paid. And so the primary aim of our project was to facilitate the development of PCOMs in relation to this specific area of difficulty, childhood feeding disorders. And we wanted to ensure that we developed a PCOM that would be evidence-based, systematically derived, and be meaningful to families and those affected. So what we did, we had a 15-week period of time from earlier this year, between February and May, and we conducted our project in 3 stages. The first phase was a very open survey of parents and carers attending our feeding disorders clinic at Great Ormond Street. And we asked some very open questions about concerns in 4 different areas. Concerns related to the child's feeding difficulty, what impact that had on their child's health and well-being, what they'd consider to be important aspects and components of optimal service delivery, and what, in their view, would constitute a positive outcome following treatment. And then we checked the themes that emerged through a focus group and some one-to-one interviews. And we used the results of that to draw up a questionnaire that we then used in phase 2 of the study. When we asked people to rate the themes that we derived in terms of importance. And then we finished that off with some in-depth telephone interviews to consolidate the potential items for inclusion in a PCOM. And what we found didn't entirely surprise us. That was having a child with a serious feeding or eating difficulty is extremely challenging and stressful. We also found that the lack of understanding and support from healthcare professionals, as well as from others known to families, alongside an absence of local treatment, was leaving many of the parents we interviewed and talked to feeling very isolated and demoralised, and that this in turn can exacerbate the problems they face and hold back recovery. We were, again, perhaps not surprised, but interested to note that families consistently identified a number of clear themes that seemed important that clinicians should know about to focus on in designing and delivering better services. We felt that the information that we obtained from this project could be useful in a number of ways, and I just want to briefly touch on those. Firstly, to inform clinicians about areas that they might not perhaps otherwise consider, but that families regularly say are important to them. And we felt that this knowledge could then be used to guide assessment and intervention to ensure that care is appropriately targeted. We have ideas about next steps, which we are hoping to take forward. Obviously, we concentrated the work so far on discussions with parents. We need to replicate that with children and young people themselves, because we need to properly explore their views in relation to their own difficulties. And we would like ultimately to be able to derive a set of person-centered outcome measures relating to this specific clinical population that could be trialled in different age groups, because of course feeding disorders occur across the age range from infancy through childhood and adolescence. And in different settings, because children and young people with feeding and eating difficulties are seen in many different types of clinic. And also using a range of delivery methods, tablet-based as well as pencil and paper, and in age-appropriate ways. And we felt that feeding disorder PCOMs could be used to track how well healthcare providers how well they're doing in terms of meeting the needs of the families that they see, but also that it may be possible to explore how such PCOMs could assist commissioners with maybe specifications for appropriate service delivery. Now, I hope I haven't whizzed through that too quickly. I think I possibly had a little bit more time to go over things, but I think I just wanted to finish by saying that Paul mentioned in his introduction about the potential for national application, and I think that some of the points on this last slide would map quite well onto thinking about how this project and extending this work could be of national relevance. So that's, I think, all I had to say.
Thank you. That sounds such an exciting project, and you've worked really hard to find out what really matters to parents and children, and there seems to be a lot of potential where that information could be used to inform clinicians about areas that they might not consider, and that things that are really important to families. So thank you very much. Right, so I think now we'll move on to Georgina, who's going to present on behalf of the North of England. Thank you, Georgina.
Thank you, Sheila. Hi, everybody. Although I'm Builders North of England commissioning support, I'm really speaking on behalf of a number of different organisations today. So this work is actually a collaboration between NECS, the experience-led commissioning programme, which I'm the National Director of, and two CCGs who are working with us, Newcastle and Gateshead CCG and South Tyneside. We're hoping that both of them will move forward with a PCOM for asthma on the back of this work. So our aim is very clear. What we wanted to do was to look at how you could build personal PCOMs that are developed by the person and the parent. In the case of this particular piece of work, the child or young person with asthma and their parent, to inform commissioning decisions and to explore some of the benefits and challenges of embedding a person-centred outcome metric within commissioning. And we were really hoping that we could actually find a way of getting 3 for the price of 1, because as we know, there's limited resources in the NHS, and that's true of commissioning resources as well. And so we wondered whether it would be possible to have an outcome measure that could potentially become an integral part of care planning, that could also provide teams with feedback at a useful level for them to take decisions. So, for instance, specialist hospital clinic or GP practice, and whether it could also be aggregated up to give commissioners insight to make better commissioning decisions, and also to hold potentially providers to account for improving people's lives. So we've been through a process of designing the PCOM, and this process is not only going on in as part of this particular piece of work, it's also going on in some other CCGs in other conditions. So we're doing work around developing a PCOM for the Better Care Fund, for MSK services, for diabetes as well, and COPD, as well as this work. But it starts off the process with doing a national review of what we already know about what it's like to live with the condition that we're developing the PCOM for. And this is an infographic that describes the experiences of children and of parents based on the national research. And as you can see by looking at it, life is pretty shitty for children who live with asthma. They have a really tough time of it, and the work that we did locally to find out what life was like for local children in Newcastle and Gateshead and South Tyneside really supports this. There was very little that we didn't hear locally. And also, I think that we perhaps underestimate the impact on parents of living with asthma, so in their child. So, you know, to the degree to which in some cases parents told us, and the national research shows, that parents can actually end up losing their job because they're taking their child to school, their child is off school a lot, ill with their asthma, and that in turn means that they miss work, and in some cases actually have to give up work. And we had stories about that from the parents locally too. So there's definitely a great opportunity for us to improve the lives of families living with asthma. And we know that actually the majority of deaths in people who have asthma from the NRAS review are in people who have mild to moderate asthma. And that caused us also to wonder whether there was something going on here around the way that the people are supported that could perhaps teach us something about what was going on that we could improve. this infographic, which will be in the slides if you go to the website to download them, but I won't go through in detail, shows the difference of Southeast Asian communities. So what this tells us is that there is also a cultural element to how people experience asthma and how it impacts on their lives. And it's slightly different to the way that other communities experience asthma, and that's a really important thing to think about. We had quite a lot of families from BME communities taking part in our work too, which was really useful and helpful. So the national data gave us an idea of what kind of outcomes matter to people, matter to enhance life for families. And looking at these, some of them you will recognise and think, yes, that makes sense, I've seen that before. What we found was by far and away the most important was parents' beliefs about asthma. And that's something that is quite invisible often in the way that people talk about asthma. In fact, what we found through the process of developing this PCOM was it was so subconscious in the parents that we were working with, that it was only when we used the national data to challenge the design of the PCOM that they actually recognised that this was at the centre of a lot of their concerns about and the way that they were supporting their child to use their inhaler. So what we found, in effect, was that often parents don't encourage their child to take their inhaler because they're worried about the long-term impact of steroids. And that's particularly true of their preventer inhaler, which of course is the inhaler that we want the child to be taking in order for them to live their life to the full. So it really confirmed for us the importance of having a national benchmark that we can work with and really positively challenge what people tell us matters, because sometimes it's subconscious. So these were the touch points within a PCOM that were chosen and co-designed by expert families in the northeast of England. And as you can see, there's quite a close synergy between what matters to parents and what matters to children, although getting a good night's sleep is something that came up particularly for children, and it's interesting that it didn't come up perhaps for parents. But parents, a lot of their focus is on what they can do to support their child with their treatment and management of asthma. So there's something about us recognising that self-management in a condition like a chronic condition like asthma is actually a kind of partnership between the parent and the child, as much as it is a partnership between the parent and the professionals who are supporting them. So what is going to come out of this? So now that we've designed this tool, we're now going out to speak to a group of 50 people and parents and children and young people about their outcomes and what matters to them in their life, using a PCOM tool that's going to help them to unpack that for themselves. And this is the data set that we're going to collect to help us to make sense of this at a CCG level. So first of all, what we will be seeking to understand is how many people are moving towards their goal for each of these domains. So if we take school life as an example, how many children are moving towards having a better experience of school, and how many are staying the same, and how many are getting further away from their goals. So that's what the little row of people represents. So for this particular example, you would have 60% of people who are getting closer to their goal, 20% who are staying the same, and 20% who are getting worse. So the net life improver score for this domain would be +2, because 20% more people are getting closer to their goal than are moving away or staying the same. We're also going to be able to look at where they sit right now compared to last year, if you like. So we want to see whether they've got closer to their goal. But actually what also really matters is whether or not their goals have changed, because if people's lives have got a lot better, then hopefully their goal has also got a lot more ambitious. And if that happens, then they might still be further away from their goal. But if the goal is a bigger goal, that's not necessarily a negative thing. So the average distance from goal is actually, if you like, tempered by how ambitious the person's goal is. And then we're going to have some qualitative insights into how people's goals are changing, where people are right now and what's working for them and what's stopping them achieving their goals. And all of that qualitative insight that will be aggregated up to CCG level will provide the CCGs with a lot of insight into what needs to change. And in fact, the process of developing the PCOM has already given them a lot of that. I've run out of time pretty much, but I'm just going to very quickly leave with you a slide about what we've learned through this process. So we've actually got quite a lot of lessons in terms of the organisational development challenges of doing this at a CCG level. And I've just listed a few of those for you there, which hopefully you can see and have a little contemplate on, and happy to take any more questions. So thank you very much for that.
Thank you, Georgina. That sounds like a really good example of collaborative working and a whole family approach to develop metrics for PCOMs. I liked your example of the cultural element being important as well, in that this just shows that we can't make assumptions about what is important to people. We've got to ask them. So on that point, I think it's quite timely to move over to Nasser, who's going to share his tips and resources for effective engagement. Thank you, Nasser.
Hi there. So I'm going to be very cautious. I don't want to really teach people how to suck eggs, because obviously you already know the area quite well. But what I want to do is cover some of the general principles around patient public involvement, patient public voice, and then really lead on to some of the national stuff that we're working on to try and amplify that and embed it within the organisation. So my first slide is really a question. So why involve patients? So we have a legal duty, which is the Health and Social Care Act, Section 13Q, which indicates that we have a duty to involve patients in any service changes that impact the services they receive. So alongside that, obviously, we've got other kind of mandated commitments. Our values and constitution also seeks to put patients at the heart of what we do. So the slogan of no decision about me without me. When involving patients, we get a valuable new perspective from the service user. So I guess looking at lived experience and how that could enhance our thinking about service provision. Also, there's academic evidence out there to suggest that co-production joint working produces services which are more responsive to local need. So what are some of the good practice principles? So building on patient voice, it's about trying to get that into the mainstream, so ensuring that it's not an add-on, it's actually embedded and an integral part of our work. Ensuring that we resource patient public voice activities appropriately, so ensuring that when we think about program budgets that we have resource put aside for staff budgeting, for kind of expenses around venue, travel, etc., to ensure that the work around patient public involvement is amply resourced. It's to kind of think about communication and timing when working with reps and people, external stakeholders to the organisation. So, for example, volunteers are not always able to read last-minute documents or get to meetings due to urgent changes at very last minute. So it's thinking ahead about what practical logistics they need to take on board to ensure that they are able to contribute and get their voice heard. And finally, it's about involving more than just one patient and public voice rep. And I guess this with the argument of bringing kind of balance and diversity into the conversation, but also ensuring that the Labour representative has an element of peer-to-peer support, so they don't feel isolated and feel supported in what they bring to the conversation. So some good practice tips. So I guess what I'm getting at here, recruitment, so it's obviously advertise as widely as possible and ensure that people are aware of the mechanisms that you're using. Also think about using the existing patient and public networks, so they may already be established within your organisation. But it's also thinking about working with some of your wider partners, voluntary sector, etc. It's good practice to develop a welcome pack. So when people do come on board to be part of your work, it's good to be able to introduce them to some of the context around the organisation and also put, I guess, in black and white some of the expectations around what they'd be expected to do within the role that they're acting in. And you can also use that as an opportunity to kind of address confidentiality, conflicts of interest and other issues. Expenses, really important one. If we don't cover expenses, it usually scares people off from actually getting involved. So there should be a commitment to always cover expenses, but at the very least trying to cover travel if possible, and other out-of-pocket expenses. Also to think about kind of involvement payments or an honorarium. Can those be made, and are there any arrangements in place for those to be made? Some of which could be or would be covered in the expenses policies that we have here within NHS England. Also thinking about kind of reviewing and meeting support needs. So thinking about the person you want to bring in to support you with your work, we need to think about their support needs, ensuring that they have the knowledge and skills to be able to contribute effectively. So again, thinking about their development as well, in terms of how can we support them to contribute more, rather than just what can we get out of them in terms of their input and influence. Common pitfalls. So what are the things we always trip up on? So usually people advertise at very last minute. So in terms we don't get very uptake, so people don't apply. Usually there's a lack of support again, and engagement opportunities. So touching on what I just covered a second ago. So any failure to support individuals, especially in the initial few months, usually means that we end up with quite a high dropout rate in terms of people wanting to get involved. Failure to pay expenses promptly usually means that people are left out of pocket. So it's really important, again, to think about these systems prior to bringing people on board to ensure, as I said, that their immediate out-of-pocket expenses are covered. And the obvious one is jargon. We all fall in this trap. So making sure that the language we use is understandable and accessible by everybody. So next I want to kind of touch on something called bite-sized guides. So all the stuff I've just covered via the various slides you will find within these guides. So these are documents that have been developed by NHS England over the past year or so, and are based on review, research and best practice reports. They're available on the internet and the intranet. Currently, I think there's 4 that are live, which are the ones that are listed there. There's a further 10 that will come out this financial year, with another batch being planned for next year. But those will be dependent on feedback gathered in terms of what other topics would people like to see. They're predominantly aimed at commissioners, so it's arming commissioners with, I guess, some knowledge around core principles and how they can embed patient public voice into their daily activity. So I want to move on quickly to the national picture. So what are we working on, I guess, nationally around amplifying and extending the reach of a patient public voice in the work that we do. So there's 3 programs in particular that I want to touch on, something called NHS Citizen, NHS People Bank, and also the Participation Academy. Please bear in mind these are all kind of tentative titles, so names may change, but the idea is that they form one whole system. This is a quick, I guess, piece of concept art or diagram in terms of how they all fit together. And as I said, the theory is that each system supports the other. So NHS Citizen is around amplifying public voice. So this is about a system in the public domain that is independent of NHS England, where members of the public can have conversations and raise areas of interest directly to the board. People Bank is about formal engagement opportunities and how we can draw people in to get involved in the work that we do. And Participation Academy is a sort of a knowledge or learning hub, and it's about sharing and learning resources, sharing and learning from each other in terms of resources. So what is the current picture? So we have no system in place to have a managed approach to public engagement. So there's a massive risk around kind of continuing to approach engagement in this ad hoc manner, which could ultimately lead to individuals or stakeholders inundated with requests or losing interest based on how we market and advertise what they could get involved in. And as I said, this could kind of further marginalise individuals, communities wanting to get involved in the future. So based on that, we really do see an opportunity to develop one system across NHS England to provide opportunities for engagement and support in training and development for people wanting to get involved in NHS England, I guess, commission decisions. And it's probably worth mentioning at this point that all 3 are prototypes and they're all being commissioned separately. The idea is that we build them, we get the basic prototypes in place and test them prior to kind of rolling out and going live. And the idea is that at the moment we'd look at purely, for example, using the people, we'd look at only national engagement opportunities. And if it works well with that, we could look at scaling it down or up, depending, and extending the reach of the systems. So I'm going to go into a bit more depth about NHS Citizen. As I said, it's a social movement or system, if you will, and it's kind of been put in place to respond to, yes, how do we create a genuinely open network? How do we work on and offline spaces? And how do we listen more effectively to the many voices out there in terms of how we run the National Health Service? So the purpose really is to give citizens and organisations a direct, transparent route to the heart of NHS England decision-making processes. So this is an avenue to speak directly to the NHS England board. It's also an opportunity to give the NHS England board and others a new source of evidence and opinion on the NHS now and in the future. It gives the public an open and robust accountability mechanism for the work of NHS England, and it also helps to establish a mechanism system that leads to action quickly. To summarise, it's a space for debate. Citizens set the agenda, and it belongs to the NHS People Bank, as I referred to it earlier. So this is more about invite members of the public formally to get involved in NHS England activities. So it's sort of a dating website, if you will. It's a way for people to register their profile and then have that matched up to what engagement opportunities are available within NHS England. And the idea is that the system would handle those interactions. So it's an opportunity to, as I said, directly connect citizens to information about opportunities that are available, support citizens to get involved, ensuring that they don't need to understand organisational boundaries and just get to the issues that immediately concern them or the areas that they're interested in. And it's also a way for them to be able to feedback their experiences of engagement, for us to kind of understand what we're doing well and what we're... I'll quickly go over this one because I know I'm running over time, but this is a sort of a illustration of how the 3 systems again fit together, with the People Bank being quite central in terms of a repository. And last but not least, Participation Academy. So this is a system that is for both members of the public and staff, and it's really a central online space to develop opportunities for people to share learning and experiences around participation, for them to participate in learning opportunities and offer learning opportunities, to identify useful tools and resources, also to offer kind of links to other offline work that kind of bespoke to specific communities, often locally, for example, through local health watch or other voluntary sector learning opportunities. And it also will help us build an effective evidence of effective participation. So, in summary, NHS Citizen, as I said, is about amplifying citizen voice. People Bank is around connecting people to form participation opportunities, and participation academies to learn participation skills and practice. And that concludes my presentation. Thank you.
Thank you, and that's some really useful tips and resources there for people to access. Right, well, I'd like to say thank you to all our speakers today. I found that really exciting and inspiring. I hope you all did too. We now have some time for questions. I can see that there are a few in the chat box, so we will work through those. Please do ask any questions that you have so that we can try and generate a discussion. Our first question is from Jennifer George. Would you like to ask your question, Jennifer?
Yes, can you hear me?
Yes.
Yes. Yeah, it was just from the first presentation from Great Ormond Street. It was whether you've actually got an example of some of the measures, so the actual example of the indicator measure rather than kind of the area that you were measuring.
Well, we are currently working on putting that together, and because obviously we've got the information that we need in relation to those areas, and then we're wanting to, the next step is to trial that and work it up a little bit more. Okay. So we are currently working on that, because obviously the idea is to have a sort of formalised measure. But that's in progress, and we're hoping to be able to produce that pretty soon.
Lovely, thank you. Is there anything from the northeast that's available to share?
Yeah, I did have them on there. We've got the 6 areas of, so they're on the presentation. There's 6 domains that parents have chosen and 6 domains that children have chosen. And the process that we use to then gather data will be about asking people about what good looks like for them around their school life or living with their medicines or whatever it is, and then we'll make sense of all of that at a CCG level.
And that's what you're commissioned against?
That's right. Yeah, that's the idea. The CCG are currently just deciding how to, sort of respond to. They really see the potential of the PCOM, but what we found was that specialist care is actually delivering a much better outcome for people and for children and families than GP care, and so the best place to really have impact is by using the PCOM in primary care. And obviously CCGs don't necessarily commission primary care at the moment, although this CCG is looking to do co-commissioning. So we're looking at how we can work with them to help them to work out how to embed this. Ideally, they want to hold both specialists and primary care accountable through the PCOM. So it's likely to become a sort of system level measure rather than one for a particular provider.
Okay, thank you.
Right, we had 2 questions from Liz Slater. One of them was regarding the bite-sized guide, which I think Paul Gavin has now answered. Is that correct, Liz?
Yes, that's correct.
That's great. And what was your other question, Liz?
It's around whether primary care has been engaged with the asthma PCOM, but I think Georgina's just answered that question in her previous answer.
Yeah, I mean, in an ideal world, what we're hoping is that the PCOM becomes a care planning tool for and gets embedded into routine care. But what we know also from a lot of the other PCOM pilots that have been done is that getting clinicians to use a PCOM can be quite challenging. So for the purposes of this particular pilot, it's actually volunteers from an organisation called Involve Northeast who are going to be doing kind of peer research with people, children and families living with asthma to gather the PCOM data. But ultimately, GPs will be, hopefully held to account through the PCOM and specialists too.
Okay, thank you.
Thank you. I can't see any more questions in the chat box, but I'm interested to ask a question in terms of, has anyone else developed PCOMs? If you raise your hand, if you have, and you'd like to share what you've done.
So, Julianne?
Oh, hi,
I
Julianne.
actually had a couple of questions I wanted to ask rather than answer that question, so perhaps come back to me.
That's fine, that's fine. You go ahead, Julianne, and we can come back to the other.
Okay. I've been connected to this through Georgina, but one of the questions that I'm interested in is anybody doing any work with PCOMs in care homes?
Well, not specifically that I'm aware of, although some of my other colleagues might be aware of work going on, and it is one of the areas that we need to focus on as part of our engagement in terms of gathering the views of people in terms of what really matters to them. So it's something that we will do, but I'm not aware of any work as yet.
And then my second question is there any work that's been done on PCOMs at the individual level as part of the care planning process, where it is the individual that is identifying what matters to them, rather than this sort of local research about what matters generally?
Yeah, just to clarify that our project was very much asking people individually what mattered to them.
And then that becomes part of the care planning process, and what you're measuring is whether you deliver that back to them as an individual.
Yes, indeed, but also so you can use it at an individual level. And so what we did, because what was happening was we asked people on an individual basis what matters to you, and there were certain patterns and themes emerging. So then you can put that together in terms of, in general, these things, I guess similar to Georgina was saying, but in our case are slightly different themes. These things seem generally to be quite important. They will be more or less important to different individuals, but from a care planning point of view, the service providers need to know that these things generally are likely to be important, and so you need to pay attention to them, but that there might also, alongside that, be other individual factors that would be important. Does that make sense?
Yep, no, that's helpful, thank you.
Paul, I noticed you've got your hand up. Have you got a response to that or a question?
Yes, I was just really adding weight to the point Rachel made, in that all of the sites that we have at the moment are, the information is stemming from the individual, and the challenge for us is much more, is there a route from the individual to general population? Can I also go back to the previous question about other PCOMs that are being commissioned? We know that they are being commissioned, and companies like outcome-based healthcare are, similar to Georgina, helping CCGs and trusts fill this void. So they are being commissioned, and this is the challenge for NHS England to be cognizant of what is going on as we develop our policy, so that when we announce our policy, it is not out of step with what is actually custom and practice in the community. So I'm afraid that's a bit of an answer. I can't give you, I can't point you to the PCOMs that are being commissioned, but we do know they are being commissioned. And some of them, the terminology PROMs, PCOMs is there's a bit of play with those terms, and things that we would consider PCOMs are being called PROMs and vice versa. So yes, activity is taking place around the country. We do know that.
Thank you. Rob, you've got your hand up?
Yeah, it was just in response to Julian's question about care homes, and I did post something in the chat box to say that, well, not necessarily a measure as such. The presentation by the Extra Care Charitable Trust at the Long-Term Conditions Conference a few weeks ago is very much in line with the theme of this work in terms of looking at what outcomes people want. So they provide sheltered housing and support for older residents and work with them, basically looking at them as a whole person rather than the particular condition. Obviously, given the fact that many people with long-term conditions have multiple conditions. And some of the work that's coming out of that, some of the research that's been done behind that by Aston University is very interesting. So, you know, the report shows that NHS costs to these residents have been cut by 38% within 12 months of them moving into these villages or residential situations. And things such as an improvement in their autobiographical memory, where people can recall events. So if we're looking at dementia and issues around that, then the idea that, yeah, you know, I used to go on holiday to Blackpool or whatever is a memory, but that autobiographical detail behind it is, you know, we used to go as a family every July, and we used to stay in this particular hotel near the beach, and we used to do this, we used to do that. It's far more rich autobiographical memory. So there is, you know, evidence that actually looking at people not as a condition, but in a holistic manner and what they want to achieve has major impacts, both in terms of the individual's health, but also obviously part of this work is about, can this actually improve the situation in the NHS, which is under so much pressure? And if we can cut costs for older people by 38% in 12 months by working on a person-centred basis, then this is obviously something that we really need to be following through.
Thanks, Rob. Georgina.
Yeah, if I can just add, can you hear me?
Yes, yeah. We can. Yeah.
If I can just add to that, so a couple of things. Although we haven't done any work in care homes yet, we have done work with people, adults with complex care needs living in the community, and they've helped us to develop a PCOM along very similar lines to the one that we've described today for asthma. And they are the plan in that CCG. Because we're dealing with a much smaller group of people, is for that PCOM to become part of the care planning process. So the way that PCOM will be operationalised is that the person who's doing care planning with the person will go through the PCOM, set the goals, or the person will set the goals. We'll get a copy of that data. It will be extracted from that conversation, and then we will make sense of it at a community level, and then we will look for the trends in how, whether or not people's goals are getting more ambitious, whether they are getting more socially connected, whether they've got more things to do in their lives, whether they can get out and about and do those things, whether their mobility is staying the same or getting worse, and how that's impacting on their life. And all of that will be used as part of, hopefully, the contracting process. So that's the first thing. The second thing, just picking up on what Rob's just said, we've also done work comparing where people live and how where you live impacts on your outcomes. And we found very similar information about sheltered accommodation versus people who live in their own homes. And interestingly, the big one around sheltered accommodation is that actually what people seem to feel much more confident about preventing a crisis in their healthcare if they live in a sheltered accommodation setting as opposed to in their own homes. And this is a fundamentally important finding, as Rob rightly said, for the whole system transformation thinking that's going on at the moment in the NHS. And in the area where we found this, in the first instance, actually that insight caused the whole system to stop and actually start to look at some of their decisions, because what's happening a lot in local authorities is that wardens in sheltered accommodation are actually being, decommissioned, and actually what this work showed was that could actually have a significant impact on NHS resource use in the longer term. So it's really interesting how when we work with this kind of data, we get very different insights that can be very, very important for commissioners in terms of achieving their goals, which may be quite process and service use orientated, but this is like the iceberg that's under the water, and it makes the invisible much more visible to commissioners, which is a really important aspect of this work, I think.
Well, I think we're coming to the end of our session today. I'd like to thank you once again, all of you, for joining us today, and a special thank you to all our speakers. We very much appreciate it. The slides will be available on the NHS IQ website. Our next PCOM powwow will be on December the 15th, where we have Daniela Hurst from Great Ormond Street talking about the other project there, and also Nikki Hayes from the West of England sharing their learning as pathfinders along with our expert speaker, Zoe Porter, who will be talking about the Integrated Personal Commissioning Programme. I hope you're able to join us. Many thanks. Bye-bye.